Now we're going to turn to another example, which is the state of Arkansas, which has implemented some of these models as well. So I'm pleased to introduce now Dr. Joe Thompson, who is Surgeon General for the state of Arkansas.
Thank you. Thank you for having us here. It's an exciting time. Let me define Surgeon General. I'm actually a pediatrician in the College of Medicine of University of Arkansas, for which the last decade, two governors, one Republican Governor Huckabee, now Democratic Governor Beebe, have asked me to serve as their strategic advisor on their cabinet. So it's a unique perspective that I'm going to bring you in a report from the field. If we could go forward. About 4 years ago, in the middle of the recession, with rising healthcare costs and decreasing state revenue, the governor asked me, why is this a problem? And I said, because our payment incentives are not aligned for outcomes, they're aligned for volume. And he said, fix it. So we went to work to try to fix it. We first started with a workforce strategic plan. We had no strategic plan for our state for workforce. We second added a strong effort on health information technology. Many of our physicians were not using the electronic health record. We have done a unique private option expansion of Medicaid for over 200,000, 85% of our target population in the last 6 months. That's another talk that I won't go into. But to be able to afford the expansion, we had to modify the way we were paying. So in the discussion on the payment side, what became clear is that lots of people had tried lots of things, but they were always from the perspective of the individual payer. It was Medicaid trying something. It was Blue Cross trying something. It was QualChoice trying something, or Medicare trying something. So we actually went to the 4 major payers, and we said, how do we bring the incentives together? Because we need to put new resources into the clinical care system if we expect them to transform out of their traditional fee-for-service system. We had to align the incentives of every payer to reinforce that transformation. And then we had to provide actual support in terms of stability for those providers to be able to move forward. So we started with QualChoice, Blue Cross, Medicaid. They were having the same conversation, but using different language. They're 2 very different programs. Medicaid, an entitlement guaranteed program, draw down money from the federal government. Private carriers, fixed pool of money that they're managing to an actuarial cost. We attracted other carriers. And finally, we started getting our self-insureds, the state employees, the University of Arkansas employees, and even told a national corporation that what we were doing was unique and different. So let me share with you how that works. Our approach meant putting a quarterback always in charge of the patient. Now, we have some technical words in our Medicaid rules for this of what it is, but effectively a quarterback always in charge, whether it was in the patient-centered medical home space or in the acute inflammatory space for asthma, a hospitalization, or an ER visit. Let's go to the patient-centered medical home. This is not a building. This is a physician-led team paid to be responsible for keeping that child or that adult healthy. It includes nurse practitioners that can be the primary care provider. It includes care coordinators. It reaches outside for community health workers. It touches the pharmacist. Our goal is to have that patient-centered medical home team wrapped around the patient with resources coming to it, the dollars per member per month, and that they are responsible for the best outcomes and the total cost of care for each individual patient. They get 50% of the savings of the system for the total cost of care for reaching out and wrapping around the individual. Now, what they don't want to have happen is an emergency room visit for an asthmatic or a hospitalization. But when it does happen, we want there to be a quarterback inside of the hospital system responsible for the individual, making sure that the right thing happens at the right time, making sure that we avoid potential quality problems or harm, and that when the child leaves the hospital, the quarterback's still in charge for the next 30 days. In other words, an ER visit or a hospitalization makes this individual at the hospital responsible for the post-hospital care and the reconnection back over into the patient-centered medical home. If they get it right, and we use Arkansas-specific numbers to say what that is, with quality indicators required first, then they can actually get part of the savings back. If they get it wrong, they're a high-cost provider, they have a readmission, they didn't get the child reconnected with the patient-centered medical home, they owe money back. So in the bundle, it's a two-sided risk model. In the patient-centered medical home, it's gain sharing only. We have now a significant proportion of our population under this effort. Going forward, I think what's going to be the biggest challenge is attracting Medicare to be a participant in our player. We are publicly committed to getting 70 to 80% of all purchases under a value-based option in the next 2 to 3 years. We're well on our way with a multi-payer effort. We have about 15 bundles out and operational, one of which is asthma. We have our patient-centered medical homes with over 70% of our Medicaid beneficiaries under a shared savings patient-centered medical home model. And importantly, in our insurance marketplace, which is where our private option Medicaid beneficiaries are now, every carrier is required to participate in our patient-centered medical home model with per member per month payments and shared savings. Our goal is to have every payer unified in the signal and in the reinforcement of financial incentives into our clinical community to change from a fee-for-service volume-based model to an outcomes-based model, which will get what you want as a parent and other parents of asthmatics across the United States: high quality, continuous wraparound care.